My name's Drinkle, and it's 5 Chandos Road.
Could you turn, please, to bundle 4, and it's page 1239. You have that in front of you. You have the submission, which is made up of 3 separate documents. Can you confirm that they are true to the best of your knowledge and understanding, and that you wish to understand your evidence before the Commission?
Yeah.
Now, there are 3 parts to the documents that you've submitted. The first one, the one in the centre, and it starts at page 1243, is a paper on primary and community care not being a panacea. Can you confirm, because it doesn't say whether you are the author of that?
I wrote it, yeah.
Thank you. And secondly, I'd like to begin by looking at the other 2 documents. The first one starting on 1239. Now that is an interview with an emergency nurse practitioner, and the document at the end is an anonymised email from an Imperial College Trust employee.
Where's the email?
At the back, and the email is at the end of the end of your
Good.
Can you please explain how and why those 2 documents have come into your possession?
Yeah. Well, I'm the secretary of Save Our Hospitals, so we put out an email asking for any evidence that people felt they would be nervous to give directly because they were working and worried. So an emergency nurse practitioner contacted me and said that she'd give evidence, but she wanted to give it anonymously. So I arranged to interview her, and that was the first thing. And then the email was something that came through on our email communications.
Well, did either of those people give you any specific reasons why they felt the need for anonymity?
Both of them said it was more than their job's worth, paraphrasing them absolutely clearly.
Anne, can you speak up a bit, please?
Sorry. How's that?
Fine, better.
Okay.
Could you just repeat that last time?
Yeah, both of them were very clear it was more than their job's worth.
Now, because these are documents that you've brought in but that you haven't written, are you able to comment on the contents at all?
Well, the email, I haven't had more interaction than that, so that really has to stand by itself. And I took some bits of the email out that might have made people able to identify that person. The interview is somebody who I've had long discussions with, and she's authorised me to speak about the interview, so I feel comfortable doing that.
Bearing that in mind and bearing the context of that, can you assist the Commission with your take on the confusion between urgent care centres and accident and emergency departments?
Yeah, I should say I have worked as a nurse practitioner, and I have worked in a walk-in centre, and I've been a nurse practitioner in a homeless clinic, so I have some personal experience as well. I think that there is a huge amount of confusion around the differences. I think the evidence is that urgent care centres work best when they're co-located with A&Es. That makes perfect sense then, because you can triage, and if you need more backup, then you've got it in the A&E departments. I think that the fact that the Shaping a Healthier Future plans say there will be A&E departments when they're effectively talking about something that's more like an urgent care is actually quite irresponsible long term. At the moment, there is still no standard for what an urgent care centre does, and I think that makes it quite confusing. And actually, I think there are also internal issues. So, for example, within the document, you'll see that the nurse practitioner reports that in some areas, GP consortiums are urging nurses to turn away, redirect patients who come to urgent care centres back to the GP practices because they don't want to sort of pay twice for treatment.
Can you pause pause there for a moment. Could you explain a little more carefully what a redirection policy means?
Yeah.
If you look
Okay.
at 1241,
Yeah.
and it's 3 paragraphs down, the nurse practitioner says, in KMC, some of the practices now have a redirection policy. And goes on to explain, but I wonder if you could encapsulate, as obviously you're...
So what it is if the GPs, I presume, are thinking there's a duplication of resources and they don't want to have to pay twice for it. So if one of their patients, what you have to do if you work in that clinic, if a patient comes from one of those practices, this is slightly second-hand, so I'm not, but this is as I understand it, you have to contact the practice and check that there are no appointments possible that that person will be able to be seen by in an appropriate time. If there are, you're not supposed to treat the person, you're supposed to send them back to the GP practice where they will deal with them. What the emergency nurse practitioner I interviewed talked about was just how time-consuming that is, because, you know, you're really busy, you've got a room full of really needy people and you're messing about trying to get through to the practice on the phone and then fill in all of the stats and so on. So she said it's very time-consuming and it's obviously both annoying, distressing and confusing for the patient.
So can I just be clear about this? It is what you were saying, that if a member of the public arrives at an urgent care centre, one of the questions they will be asked is, where are you from, or who is your GP?
Not generally. It's only this particular... What I'm saying is that new forms of confusion are happening in little pockets locally. So this is just a small pocket, an area where this particular problem's happening. And at the last scrutiny committee, one of the Conservative councillors in Hammersmith and Fulham raised another little idiosyncrasy which complicates things, because he was talking about patients who are not registered with GPs being asked to pay at Parsons Green Walk-in Centre if they had treatment. Now, I don't know if that's true or not, but he talked about that at the scrutiny committee last Monday. And it's just examples of how it's extremely idiosyncratic what goes on still.
So in terms of the urgent care centres, is it the case then that there isn't a consistency of approach? Is that what you're looking at?
Absolutely. I mean, even within urgent care centres, it depends who you're treated by. You might have an urgency, you know, in terms of skills. So some emergency nurse practitioners will have extended prescribing and be able to prescribe pretty well anything a doctor could. Some won't. Some doctors are less confident with trauma and actual accident injuries and would prefer medical conditions. So and the fact that staffing is such a big problem, particularly within CLCH, means that a lot of the staffing at the moment is, or quite, you know, a high proportion is bank and agency. And again, you've got less standardisation then about what skills those people bring in.
Now, just still on the question of urgent care centres, one of the other things that the nurse practitioner says, and this is at 1242, I don't always get the impression services are working together for the patient's best interests. There are turf wars between 111 and the UCC doctors about who should see particular patients. Are you able to explain what's going on here?
I think she was referring to when the urgent care centres are either near the end of a shift, and I think the urgent care, for example, they may want to push the referral over to 111 service, and 111 service don't want to give it to them. I think that's one issue. And just more generally, there are lots of turf wars about whether it's reasonable to ask people to come in to be seen, whether they will do home visits. The guidelines aren't clear, and there's a lot of scope for people who are under pressure trying to pass the buck.
Is there a financial implication involved in who is seen where?
There is, because obviously there's a cost to being seen. There's the cost of the consultation. I don't know if that's the reason or not. I couldn't speak to that.
Can't take that into account. Can I just ask you very briefly, then, just to have a look at the email, and it is at 1253, and this is the email that we've just referred to. And I realise you said that you don't have any background detail, but are you able to help with, without providing identification, what level or type of employee this is from?
That person is an experienced staff nurse who's been in the trust for a number of years.
And her comment, that information that is being fed to the local community is far from reality. Are you able to make any comment on that assertion or not? I
absolutely know that's the case. I know that from my own clinical practice, and I know that from my position in the campaign. And actually, I think it's one of the really big problems of the whole health economy here, that because there's such a pressure on corporate reputations and getting business and looking good, bad news in terms of poor performance or vacancies or whatever is swept under the carpet. So that's why it's so hard to get a serious debate about what could be improved and what needs to happen.
So is it your evidence to the Commission that you have direct knowledge of wrong or faulty information being promulgated? I'm not talking about falsehoods, but for example, I'm talking about quite selective information. So if you look at, for example, vacancy rates amongst community nursing, which is massively, massively high, I think the community trust would acknowledge that's a problem. I think there's an overall, James Riley, the chief executive, said last week there was a 17.6 vacancy rate, and they have that as a red risk. But actually, if you dig beyond that, the figures for clinical staff are higher, and for community nursing, they're significantly higher. So that, for example, in Hammersmith and Fulham, for trained district nurses, there's a 60% vacancy rate. 60?
Yes. There's only one district nurse in place for the whole of Hammersmith and Fulham this year. There are 15 community nursing vacancies. And, you know, that broad brushstroke doesn't get down to that kind of level of detail, which is what you need if you're really going to assess whether the service is capable of delivering or not.
Can we turn now to your central submission? What your premise appears to be is that the primary care and the out-of-hospital initiatives won't do what Shaping a Healthier Future says they will do. Is that your premise?
It is. I mean, I'm very for primary and community care. It's what I've spent my professional life doing and pioneering. And I know of lots of out-of-hospital strategies locally that are really useful and good and probably will deliver something and should be supported. I think the issue is that they haven't been tried and tested. They need to be properly resourced. And unless they're delivered on a much bigger scale, for a much longer time and on a much wider premise, then although they'll be very good and very useful in themselves, they're not going to stop the tide of unplanned admissions and deliver what SAHF wanted to deliver.
So just breaking it down, the current state of out-of-hospital services in the borough is what?
I think there are some very interesting pilot projects going on. I think there are small examples of some positive developments. I think the CIS project, which is a sort of virtual ward type of thing, is potentially very useful.
Can you just tell us what that acronym is?
Community Independent Service. But it only lasts for 6 weeks, and it only involves a limited number of patients. And also what I should say is one of the reasons it will probably deliver good things is because it's well resourced and it's got highly motivated staff. The problem is they're not coming from anywhere else except the ordinary pool of community nursing staff. So actually what they do is they often take the most kind of lively people from the bread and butter district nursing service. And what they then do, if they work well, is they then generate referrals back to the district nursing service, which has been depleted, so that although you can get these kind of small pockets of very good performance, it's against the backdrop of you've kind of privileged that little service at the expense of the bread and butter stuff.
So is this robbing Peter to pay Paul?
Yeah.
Now,
Killing Paul.
to what extent do you consider that the relevant clinical commissioning groups have understood this?
I think there's a really big problem. I think there is that problem about not being able to hear the message, and I think both across Imperial and the CCG and CLCH, it's such a sort of tough corporate world, and they're so busy trying to get a big enough share of the market to survive and become foundation trust and meet all those targets, that there's lots of reasons why they wouldn't want to necessarily pay great attention to bad news. I think that's one factor. Then I also think there's a kind of increasing disconnect really between a leadership and the people, the clinicians on the ground, who, to be honest, mostly now your workload is so high. If you look at, for example, CLCH's vacancy rate I've talked about, they've got really high sickness rates. A lot of their sickness is stress. They've got a really high turnover of staff. I know from all the colleagues I used to work with, their workload in terms of number of visits a day is at least double what it used to be, if not more, with more expectations as well. And what that means is a real exhaustion and difficulty engaging when you get a medal if you finish the day job, and then trying also to engage with all of this stuff is really difficult. And I think on a more broader level, the King's Fund have just put some evidence out about how within the CCGs there's an increasing disengagement between the GPs who are on the face doing the consultations all the time and the senior leadership, and I think that's a phenomenon we see here as well.
Have you had any conversations with GPs which would underpin the evidence you've just said?
Yeah, I mean, yesterday. Yeah.
Are you able to give a flavour without giving identifying details?
Well, I was speaking to a GP who I have worked with for a number of years, who rang me up to wish me luck for today, said he wished he could be here, but that he was too worried about the consequences, and he didn't think there was much point because he didn't think things would be able to change. And he's somebody who I have masses of respect for as a clinical pioneer.
And is that an isolated conversation?
No, not at all.
Something you've heard more than once?
Yeah.
I wanted to ask you just briefly...
Oh, and sorry, I should say that we have a number of GPs and hospital doctors on consultants. We have a kind of weekly email newsletter that reaches about 500 people, and there's there's about 40 GPs and doctors and consultants on that.
And are they aware of the existence of the Commission?
They are, yeah. No, we've tried hard. There is a real culture of nervousness about getting involved, and I think partly that it feels like we're not some little place in the country where we're taking on a little health board. The hospital trusts here are very, very big. They are, for example, they're very good as well. I wouldn't want to knock Imperial's results, because in many ways they've got the best mortality rates, etc., in the country, so we want to preserve that. But it means it's a huge enterprise. There's the hospital, the NHS trust, but they've also got the college. They've got really big global ambitions in terms of that, and they've got a lot of research that links up with lots of drug companies. They've own lots of property in the area. So the point I'm trying to make is it's not an insignificant thing to challenge.
Now, just turning to some of the other issues you raised, you mentioned the frail and elderly as a particular group. Can you assist with what you say they require most in terms of services, and whether or not the current proposals under SAF can deliver that?
I think one of the most telling statistics for me is the number of pressure sores that are being recorded by CLCH on a monthly basis, because I think that's quite a good indicator of level of care. And CLCH are completely open about that.
Just
but
remind us, CLCH?
Sorry, it's Central London Community Health Trust. It's the community NHS trust for the area. They're quite open that that's a problem. And to me, it's quite an indicator of a difficulty in the main very caring staff have enough time to do what they need to do to look after patients competently. And I think another indicator, really basic things that if you can't get them right, don't tell me you can put more people out into the community, is the flu immunisation rates. We've got really, really bad flu immunisation rates, for staff within CLCH, that's around 25%, which is the lowest 10th in the country, which is pretty poor. But I'm concentrating on frail elderly people. Flu immunisation is a really good way of protecting somebody, and we've got very, very poor rates for that as well. We've put the stats for that in the paper, and I kind of think there's such basic things that honestly do make a difference to whether somebody feels well and is able to manage at home or has to go to hospital. And I mean, I could give you loads of other things, but I think let's get those really ordinary basic things right first, and then let's talk about doing something a bit more complicated.
Can you just help us by just talking us very briefly through your argument that out of hospital services won't reduce the need for acute bed space? I know that's a rather wide question.
Yeah.
But
well, I think there's quite first of all, I just think the arguments should be decoupled. I think it's wrong to make expanding out of hours depend on closing acute beds. I think you should be developing the out of hospital and primary care, and if, because it's succeeding, there's less need for hospital beds, that's absolutely fine. I know personal ties to bricks and mortar, but I think the logic that has to be decoupled. I think if you look at the stats around how we're doing at the moment, and I could go through them, but I think you probably don't want me to, but if you look at the public health outcomes which we've listed in terms of not just flu immunisation, but all of our immunisations, they're pretty poor. We're not great on a whole number of mortality rates and various illnesses. I think that it's obvious that we've got a long way to go, and I think there's things we need to do to improve that before we can look at taking anything more on. I also think there's a problem that GP practices are getting overloaded, and in a funny way, we're saying that things are so specialist in the acute service that all the hospital doctors have to be more and more specialist, and yet it's quite illogical, because actually we're expecting the poor GPs to manage more and more and more. The final part around that is, I think that all of the SAHF proposals may get blown out of the water because there are things beyond the control of the local health economy that may affect hospital admissions and health. So the wider determinants of health. So, for example, we've got a really big problem with air pollution in this borough, which causes a lot of mortality and causes a lot of hospital admissions. We've got a huge problem with child poverty in the north of the borough. We've got a huge problem with some kinds of homelessness, and up in Brent, which is only 3 miles away, the levels of rough sleeper homelessness are massive. I'm just giving examples of things that can completely disrupt any other plans, because all of them lead to a bigger demand for acute services.
So finally, can I just ask you this, just in terms of the implementation of the rest of the SAF programme, what in your view should happen now?
It's not a speech, but I just thought I better remember the main points. I think first of all there needs to be an honest debate. So I think that there has to be, people have to be prepared to listen honestly to the problems to come to some kind of useful discussion about it. And that partly means not being afraid of the public, actually genuinely engaging with the public, because to be honest, we're sort of made out to be the enemies of this process, but actually we've all got a genuine interest in getting better primary and community and acute healthcare, and we're all supporters of the NHS, so we could actually have a proper debate about it. I think that there's been too much of a focus within the trusts on stuff that isn't their main job, their clinical job. I think that's backed up by CQC reports. So, you know, being fixated around foundation trust status or getting a bigger market share has become at least as, and sometimes more important than basic clinical priorities. I mean, if you go to any of the board meetings, the board papers are piled up, and at least 50% of them are on just bureaucracy that's irrelevant. That's not just a waste of time, it's a waste of resources, and it's silly to put the very, very brilliant clinicians we have, why can't we put them in the operating theatres and in the consulting rooms instead of getting them messing about trying to get 20 more members for the foundation trust bid? And finally, I think that there does need to be adequate resources to fund all of this, and actually that doesn't seem to me as challenging if you think about how much we're wasting at the moment on competitive tenders and commissioning and blah, 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 blah. I think it would be entirely possible to have a kind of retreat back into actually practicing healthcare and medicine and ordinary decent nursing, and that would make a difference. And that doesn't mean going back to old-fashioned stuff. I think there are some fantastic out-of-hospital projects here. Like, I'll just give one example, the Coordinate My Care, which is not just about coordinating, it's about planning end-of-life care before you're too ill to make the decisions, so that people know what you want to happen, where you want to be. Now, to me, that's a fantastic initiative. If it, as a byproduct, means that people don't end in hospital, that's fine, but it's actually just a really good use of technology and communication, and it should be supported. So there are really lots of innovative things we could do, but if we could shape it so they're being done for the best clinical reasons, rather than the kind of corporate rationale that's often tied around it, I think we'd be making a better job of things.
Thank you. If you'd like to wait there may be questions from the commissioners.
Yes, thank you very much. I want to ask one question, but preface it with something you may not have heard I said this morning, which is this is intended and will be an independent commission. Secondly, we intend to focus on terms of reference, which I drafted earlier on, were all agreed, which was identifying the constituency that needs to be served, identifying the needs of that constituency and how they're best met. That can only be done if there is a transparent and honest debate, your point. Now, my concern is that a whole sector of the constituency is in fact excluding themselves because of fear. They're on your database. Now, we have already the 40, I'm talking about the 40 people. Now, they need to speak. They absolutely need to speak if we're going to progress at all, for the benefit of the community. Now, I don't want to put them in a position, and none of us do, in which we heard about one example this afternoon. That kind of harassment has to stop. However, bearing in mind, and it's a long introduction, I'm wanting, on behalf of the Commission, for your possible help with regard to those 40 or even more, because we have procedures. We can anonymise, but it can go further than that. If they're worried that what they have to say may identify which hospital they're in, well, we can deal with that as well. They want to deal with their observations or points in a general way, they can be dealt with. Now, I'm issuing this generally. Is anybody else here today who can help? Now, are you able, do you think, to go back to these 40 and see whether any of them will come out of the woodwork? Because at the moment, that whole area, we're realising, it's other people who are having to come forward and speak on their behalf. We do not want a situation, at the end of all this process and say, well, you haven't got the information, you haven't got the practitioners on the ground and all that kind of thing. That's the point.
I mean, there are some of the clinicians have been in this room today and will show support by being here, but I can really understand some of their concerns. One thing I think would make a difference is if you could do some closed sessions, because that might reassure people. I'll certainly circulate anything you give and try really hard. I'd make it a priority to get people, because I know that nothing counts as much as that. But you will know people like Charlotte Monroe and a whole lot of other health workers that have had a really tough time when they've whistleblown. And this isn't even really whistleblowing. This is telling. All I've told you, every single thing I've told you, is public information. I've got it from board papers, and people are quite nervous even about that. So I will try really hard. Our organisation will. I would suggest that closed sessions might help a bit.
I'm sorry to have this debate in public, but I think that's what we want to be, in public and transparent. So having closed sessions provides a real difficulty, because of course you're not transparent, and then how do you publish what you've heard in closed session? So it's a difficult one. I think some of us would be reluctant to go down that route. What I'm really saying is you can anonymise observations as long as we're in a position to know who the people are. We won't. We'll give undertakings that their confidentiality will not be breached in any way at all. But there has to be an effort to, as it were, provide public information to give us insights from genuine practitioners. Anyway, that's all I need to say on that, perhaps too much. Anyway, anybody? No?
I think it's very clear, the presentation. Thank you very much.
Thank you.
Yes, thank you very much.
Thank you.